My name is James Kinross. I'm a senior lecturer in surgery at Imperial College in London, and I've been working with the LumenEye now for many years. For me, it is the new standard really in digital rectoscopy. It's transformed my practice both within the office, so within outpatients, and also within the operating room. It has changed the way that I observe and survey my anastomoses after they've been performed.
So I'm Quentin Denost, I'm colorectal surgeon. I'm working in Bordeaux University Hospital in southwest of France. So I began to use the LumenEye within the last 2 years. I use it mainly in clinics to assess the tumor response after neoadjuvant treatment for rectal cancer. So it's really helpful to assess this tumor response clinically, and we add it with the MRI, obviously, but then following the scar and following the tumor response according with time, it's really helpful.
My name is Eloy Espin. I am the coordinator of the colorectal surgery unit in Hospital Vall d'Hebron in Barcelona. I'm also now the president of the ESCP, European Society of Coloproctology. For me, it has been very exciting and like a game changer in terms of that now I have a tool that gives me a high quality view in a comfortable way, and I can keep those images for the future, so I can compare the results of treatments or the time in a single patient.
I've been very lucky to be involved in the creation of some of the early data on the LumenEye system. We have seen that it is easy to adopt with a very shallow learning curve. We've seen that it has equivalence in its performance to flexible endoscopy, and that we get similar diagnostic accuracies when appraising the rectum in the outpatient setting.
It's really easy to use it in your clinics. You can reproduce this exam in different period of time during the period of assessment of the tumor response assessment. So that's why I would recommend it for other surgeons.
Watch and wait protocols for our rectal cancer patients. We are doing more local surgery, local treatments in the rectum, so that we need to check. So LumenEye for us, it's fulfilling the gap that we had tool that it was easy to handle.
At the moment, we are in a phase of development where we're trying to create use case data to support its wider adoption in standard practice, but we're also performing proprietary research to create new capabilities for this system going forward. For example, we're trying to standardize luminal surveillance of anastomoses and to make that a more acceptable methodology for colorectal surgeons. We are trying to embed it into standard practice for watch and wait algorithms. And we're also really trying to standardize its use in the assessment of 2-week wait referral pathways. So it's developing forward-thinking deep learning systems to provide decision support for clinicians using the system, or to provide diagnostic capabilities for the system.
So watch and wait is the strategy we use when the patient had complete response. I mean that we suspect there is no more tumor cells in the scar in which there is before the rectal cancer. Watch and wait, we just follow the patient very closely without doing anything more. And it includes the digital examination, the MRI, and nowadays we have to implement this digital rectoscopy in order to have a proper assessment of the tumor response. The point is you need to have the same assessment every 4 months for 2 years, every 6 months for 3 years. That means that you need to have the same evaluator and the same way of assessment. You can re-evaluate it, and in each period of time you can compare your assessment now to the previous one.
We are doing a more aggressive follow-up of those anastomoses. If you check up what we were doing 10 years ago, it was just biological diagnosis. That means that we take out some blood test and we measure some criteria. We have proper tools for that. It's the C-reactive protein. But now, a digital retroscopy that it's showing us how is that anastomosis. And this is where the LumenEye it's entering into this new way of rapid. It's something that is needed to spread, that you don't have to rely on clinical symptoms. You have to rely on biological and on the view of that anastomosis. And this should be done in all the centers that are operating rectal cancer.